Good evening, everyone. Thank you so much for your time and welcome to the FLaNET carcinoid community. Today, our topic is our paragangliomas and pheochromocytomas, a unique and rare diagnosis that has a dedicated group. And we've invited our colleagues to share some concepts from surgery, systemic medications, and genetics. I'm joined by Dr. Sarimar Agosto Salgado, Dr. Rachel Voss, and Laura Barton, who are my colleagues here at Moffitt Cancer Center, and we work as a team in treating our patients. So today we'll start with a really general overview from all of their perspectives, and we welcome questions, and we want to have an open discussion thereafter as well. We'll start with my colleague, Dr. Agosto, who joined us from Texas. She is an endocrinologist, but also is uniquely trained and educated in endocrine oncology. So she participates in the systemic treatments of particular cancers as well. And she'll be discussing those therapies. And Dr. Agosto, if you would like to share your screen, you can.
Thank you. Thank you so much for your kind introduction. It's really an honor to be here, accompanied by great colleagues who day-to-day work hand in hand in taking care of patients with this condition. So to provide some background, pheochromocytomas and paragangliomas are neuroendocrine tumors. Pheochromocytomas are basically the designation that we give this type of tumor when it originates on the adrenal gland, which is a gland that it's above each of our kidneys. It has been estimated that if we look at CT scans, how many times we find what we call in medicine an adrenal incidentaloma, that can happen between 1 to 7%, but not all adrenal lesions are pheochromocytomas. However, when we evaluate all the adrenal tumors, we have seen that pheochromocytomas have been reported in up to 8% of all of those adrenal tumors. Approximately 40% of those tumors can be associated with what we call a germline mutation, meaning that it's a hereditary predisposition to develop these tumors. And we're going to hear about a little bit more about this from one of our wonderful genetic counselors. When the tumors originate outside the adrenal glands at one of the nervous system chains in our body, whether in the abdomen or the thorax or in the head and neck, we call them paragangliomas. About 2 to 25% of pheochromocytomas can spread outside the adrenal glands, when compared to, for example, 2 to 60% of paragangliomas, meaning that these tumors can metastasize in a subset of patients. One of the things that characterizes these tumors is that they can produce certain hormones that can actually elevate the blood pressure. So if we look at the whole universe of people with high blood pressure or hypertension, about 0.1% could be having hypertension due to a pheochromocytoma or a paraganglioma. And these tumors are diagnosed between up to 16,000 cases, 1,600 cases annually in the USA, most commonly presenting kind of between the 4th to 5th decade of life, but in some familial syndromes that can vary. Sometimes we find them incidentally, as somebody had an image study due to any other reason, from a car accident leading to CT scans in the emergency room, somebody that's having cancer treatments, and during scans we find the pheochromocytomas or paragangliomas. But actually some patients can present with symptoms, and the usual classic triad of symptoms is usually present when the tumors are releasing a lot of hormones that we call metanephrines and catecholamines. And symptoms can include headache, episodes of sweating, and flushing or becoming all red. They can also feel heart rate rapidly, meaning heart palpitations. And that's usually the classic triad, but those are not necessarily the only symptoms. In fact, some patients don't experience the high blood pressure all the time. It may come out in episodes, or they can have episodes where they can become pale or short of breath or feel chest tightness or have even high blood sugars. Some people actually don't present with high blood pressure, but actually can have low blood pressure. And sadly, many times these diagnoses can go without being detected for many years because some of these symptoms are not specific to pheochromocytomas and paragangliomas. In fact, the excess of hormones sometimes can mimic what looks like a panic attack. So some of our patients, when we talk with them and they come to our center, we can actually trace back that they may have been having the symptoms for many years before the diagnosis. So how do we usually evaluate if somebody is having a suspicion of pheochromocytoma based on symptoms, or if we have a known lesion on a scan? Basically, we check a blood test that is called the plasma metanephrines, and that will tell us if there is, depending on how high that hormone looks on the blood, it can actually be diagnostic. There are occasions where if the tumor is not releasing the excess hormones all the time, sometimes we might be able to pick up the diagnosis on a 24-hour urine collection. Depending on the type of scan that was or the area of concern, we might do something called a computer tomography, or better known as a CT scan, with what we call an adrenal protocol. And that is a CT scan that will give us some very specific measurements and also some idea as the IV contrast is going in and out of the adrenal gland. It can give us an idea whether the tumor can be a pheochromocytoma or if it's a different type of tumor. Sometimes if we're looking at a potential paraganglioma in the head and neck, actually an MRI might be a better imaging modality. So your doctor and your care team will individualize what's the best image to do. And every patient that we have a concern for a pheochromocytoma or a paraganglioma, we do recommend to meet with genetic counseling. Now, not all tests, no test is perfect. And sometimes when we measure in the blood, what we call the metanephrines, which are basically these adrenaline metabolites that I talked to you about a little bit earlier that can raise the blood pressure, sometimes there are things that can make that slightly elevated in the blood and cause a false elevation. And sometimes that can be things that are other medications that patients are taking for either mood conditions, sometimes beta blockers that can be used for heart rate control. Sometimes if patients are using certain substances like cocaine, those things can also elevate and stimulants the plasma metanephrines. So everything always has to be interpreted in the context of what are the medications that the patient is taking. In addition, besides whenever we find a pheochromocytoma or a paraganglioma, if it is a very large adrenal tumor, or if we find a paraganglioma, we might do something else that we call functional imaging. And functional imaging, basically, what it does is a special type of PET scan that we call PET dotatate, which is very specific for neuroendocrine tumors and can try to identify something that we call somatostatin receptors, which is something that these tumors express, and basically they will light up better on that special type of PET scan compared to other images that are done for different cancers. If anybody that's seeing this lecture has been diagnosed with pheochromocytoma or paraganglioma for a while, your doctors may have at some point also gotten an MIBG scan, which is a different type of scan But more and more, the field it's moving towards doing a PET dotatate to better study these tumors. And there's two types. There's the gallium dotatate. Sometimes there's the copper PET scan, but they're both as valuable. One of the things that it's very important is how do we protect our patients when there is an excess of hormone from that adrenaline excess from that caused from the metanephrines to try to control the blood pressure. Well, we use a special type of medication that must always be utilized at least by 7 to 14 days before surgery or procedures if we are worried about the hormonal excess. And that type of medication, it's called an alpha blocker. There's several out there, and there's a range of doses. And basically, no patient is the same. Some patients may require higher doses of alpha blockade. Some patients may require lower doses. Whenever we start, I do tell my patients that they can feel slightly dizzy the first few days, especially standing up suddenly, because the blood pressure can lower if you stand up suddenly. But it is important to have this medication on board so that as we are doing treatment, which many times, if possible, the first line is surgery, and we'll hear from one of our amazing surgeons on the panel later on. This type of medication will give you some protection during anesthesia and during procedures, so that if there is a rush of the adrenaline metabolites, the metanephrines, that the blood pressure doesn't spike dangerously. As we have the alpha blockade on board, then eventually we add what we call a beta blocker, which is a medication that can help control how quickly the heart beats or the heart rate. It's always important to add first the alpha blocker before we add the beta blocker, because if we do it the opposite way, the blood pressure can go very, very high and result in a pheochromocytoma crisis. So as your doctors are helping control your blood pressure medication, these may not be the only medications they may need, because sometimes if there's a lot of hormonal excess, additional meds need to be incorporated. This is actually one of the only occasions where you might hear doctors telling you that it's important to stay not only well hydrated, but also have a high salt intake close to surgery, because that is really going to help keep the fluid within the blood vessels and minimize the risk of actually the blood pressure going the opposite way after surgery. We do follow our patients very closely before surgery, and we ask that you stay in communication with us, sending us your blood pressure readings so that we can help you guide how to adjust these medications. Our anesthesiology teams, they have special protocols, and then we do some close monitoring afterwards to make sure everything stays smoothly. As I mentioned in the beginning, there are some familial syndromes like multiple endocrine neoplasias, neurofibromatosis, von Hippel-Lindau, and paragangliomas syndromes type 1 to 5, which you'll hear a little bit more from our generic counselors later on. And sometimes, depending on which familial syndrome is present, it depends also on where we can find the pheochromocytoma or paraganglioma, and what type of hormonal excess we can see. We also have protocols on how to follow family members that may carry a predisposition to have a pheochromocytoma or a paraganglioma. And we do that by evaluating symptoms, blood pressure, the plasma metanephrines, and also alternating every certain amount of years scans, ideally in that context MRI, to try to minimize the exposure to radiation. And as you can see, there's very clear guidelines on the types of questions that we ask and the areas that we look for. Very, very important. Pheochromocytomas and paragangliomas, although they are not rare, to the group that is speaking to you here today, they are considered a rare type of tumor. And like with any cancer, it is really best to approach it from a team perspective, really putting the patient in the center, seeing what other medical conditions they have, having conversations between the endocrinologist or endocrine oncologist with the medical oncologist, the surgeons. Sometimes we involve radiation, nuclear medicine, as well as a whole team of specialists to support you psychologically and symptom-wise, as well as our genetic counselors to really delineate what is the best sequence of treatment. If we find a localized tumor that it's in a single region and that surgery doesn't have any contraindications to be performed, that's usually our first thought is, can we take the tumor out? And as I mentioned before, we have to have a special preparation to make sure that we try to do that safely, not only in the hands of a surgeon that has the expertise of working during these tumors, but having a whole medical team that knows how to handle the situation of an excess of metanephrines, as well as very close follow-up even before surgery, so that everything can go as smoothly as possible. And after surgery, things don't end there. We do follow our patients after they have had a surgery for a pheochromocytoma, and the timing of follow-up can vary, but typically we check for hormone excess between 6 to 8 weeks after surgery. Sometimes it can patients may need a little bit more closer follow-up if they had tumors that had a higher predisposition of being metastatic, or if they have a specific familial component that needs a more closer monitoring and checkups. And the areas and the type of scan may be very different depending on the original presentation. But sometimes we have tumors that are in a difficult location for a surgeon to intervene, and the risk of surgery would be actually worse than the actual benefit. Or we can have cases where there can be multiple paragangliomas or metastatic tumors, meaning that the disease has spread out to multiple places. Some of the common places can be the livers, the bones, the lungs. And so we do comprehensive imaging to look at where the tumors are. But one of the things that we also first try to identify is actually what is the rate of growth, and are the tumors in a location that absolutely need intervention right away. And the reason I say that is because some of these tumors actually may be not rapidly growing, or they may stay without changes for quite some time. And sometimes just actively monitoring very closely might be the route to go. Sometimes if we see that it is a single area that we have concern, we might use a therapy that's directed to that area, and we pull in one of our radiation oncologists to try to give a focal radiation. But if we have tumors that are growing, and then we evaluate how quickly they're growing when we make the decisions about which systemic therapy we will go. By systemic therapy, would mean something that would affect all the tumors that are present. And for more rapidly growing tumors, in that situation, I partner with our wonderful medical oncologist, Dr. Haider, to consider systemic cytotoxic chemotherapy, where there is a regimen of a combination of 3 chemotherapies, which we call the CVD protocol. Sometimes there could be access to what we call radiopharmaceutical therapies, which is basically the tumors that, if we see them lighting up on a PET dotatate, that ability to light up on those scans tell us that the tumor has these receptors that are the somatostatin receptors, so we can actually administer the patient a radio pharmaceutical agent that has something that is similar to somatostatin, along with an agent that would help destroy the tumors, and that is what we call peptide receptor nuclear therapy, or Lutathera more commonly, for which there are commonly right now clinical trials. We used to have a different therapy in the market called MIBG, which some of you may have received before, or you may have been hearing your doctors talk about MIBG therapy if an MIBG scan had shown activity on the tumors. However, that therapy, unfortunately, even though it was FDA approved, it's been discontinued from the market. Now, we also have sometimes patients that their tumors may be too spread out on the bones, or it might not be a good idea to give them a radiopharmaceutical agent. And we have some oral anti-cancer pills that have been used in many endocrine tumors like cabozantinib or axitinib. And more recently, there's a different medication called belzutifan that it's also in clinical trials. So the point of me mentioning all these medications is not for me to expect anybody to memorize or to be leaning one into another. It's just to show you that there's a lot of things that we take into account when we really try to determine what is the best sequence and timing of treatment, but also letting our Pheo and para warriors that there is hope in terms of that more and more we are seeing therapies that we can implement in the patients that needed to have treatment. And with that, I always recommend, seeing an expert team, try to keep a symptom diary, gather a very comprehensive family history as much as you can. Always let your doctors know which medications and supplements you're taking. And if your doctors do recommend a clinical trial, consider that, because the field has been able to bring a ray of hope to many of our patients, thankfully to those brave warriors that were willing to enroll in a clinical study. So thank you for your attention, and I will leave one of my colleagues to take the next step.
Thank you very much. And with that thought, I will invite another team member from Tumor Board, Laura Barton. We're very fortunate to have a dedicated team focused on genetics, both patient genetics, but also tumor genetics. And actually, Laura, you're involved in both. So she is a certified genetic counselor. She has been with Moffitt Cancer Center for many years and has been board certified since 2012 by the American Board of Genetic Counseling. And more recently, she's been closely working with the Clinical Genomic Action Committee, reviewing results of tumor genomics as well. So the difference between one's personal genetics and the different genetics of a tumor.
Yeah.
So Laura, I'll hand it off to you to share some of your perspective.
Thank you so much. And to start actually on that point, I think that a lot of times it's very hard for patients to kind of understand that there is a different set of genetic mutations that we're going to see in a tumor, whether it's a Pheo or a paraganglioma or any other kind of cancer. You're born with a set of genes that you get from your parents, and they're written in a certain way. And then every once in a while, cells, individual ones, make a little mistake when they're copying all that genetic information. Depending on where that mistake is, or what gene is affected by that mistake or mutation, that cell then might lose control eventually of its what we call division, where it's growing too quickly with that uncontrolled division and eventually growing into a tumor. When we talk about inherited or genetic conditions that predispose to these conditions, some of them we've known about for a very long time. MEN1, MEN2, VHL, those have been around for decades. And I think we have a very good handle on what risks are expected, what types of cancers or tumors we might see, how best to screen for those, and if they do come up, how best to treat those. What is interesting now in the world of Pheos and paragangliomas is a whole new set of genes that we've been finding. Kind of collectively, you might see them referred to as SDHX because there's SDHA, B, C, and D. Maybe AF2, well, depends on kind of who you're talking to. But all these different genes, along with a couple others, we now know predispose people to developing Pheos, paragangliomas, and sometimes other things. And some of these genes are really interesting. For the most part, they're what we call autosomal dominant, meaning you have a mutation in a parent. They've got a 50-50 chance to pass it on to any child they may have. But then there's some interesting things within that. For instance, SDHD, we think probably only manifests problems if it comes from your father and not from your mother, for some very complicated genetic reasons that I think are a little bit beyond the scope of today. But all that to say, I think that as we learn more and as the spectrum of conditions that we know are associated with these types of things grows, I think that having people with that specialty like genetic counselors is helpful, not only for patients to understand what their risks might be for not only themselves and what to do about that, but for family members. A lot of these conditions we can see manifesting in childhood. So it's one of the more rare inherited conditions that we inherited cancer conditions that we do want to test children. So I think genetic counselors can really help bridge that gap sometimes between patient understanding and what they're hearing from some of my amazingly intelligent colleagues who have so much expertise, like you were saying, on the tumor boards. Getting to hear all those different opinions is really just amazing. So happy to hear that we're all aware of recommending seeing a genetic counselor for anybody diagnosed with one of these tumors. 40% is very high in our world. And so no reason to not at least, I think, have that conversation about those pros and cons in the genetics clinic.
I want to expand a little bit about the pros and cons, because it's a point of discussion that comes up when we are introducing the concept of genetic testing, which can be a very big term. And you have an interest in bioethics as well. So how do you explain the use of genetic information and protecting that for the patient, as one question?
Mm-hmm.
And then the second is, what type of support should we take into account and should patients know about in how they communicate this to their family to also serve their healthcare?
Yeah. So in terms of that support for family, we I like to say to patients, if we do have a mutation, if you have something that I recommend you share with family, I'm going to hold your hand as much or as little as you want me to. We have a pretty standard family sharing letter that we provide that's written from me. So even if patients have family that maybe they're estranged from, they're not in close contact with, they still have an opportunity for that. I have seen many, many family members of my patients now as patients. And we have a number of resources, not just through Moffitt and our genetics team, but there are a number of support organizations like this one that we're presenting for tonight, that can help connect people, other patients who've gone through that same experience, who can speak to maybe how to bring it up. I'm a genetic counselor. I can give lots of advice, but it's not something that I've personally done. And so sometimes it's helpful to have those connections, to be able to connect those patients together to help understand how this can impact them and their family, both kind of psychosocially and those interpersonal family dynamics, and then also all those practical concerns, which I think brings me to your first question about some of the risks and the protections and the concerns that are brought up, maybe on a more practical front from patients. I think there are laws in place. So I'm going to back up just a minute. So one of the biggest concerns that I hear sometimes from people, especially with these types of conditions that are we're going to recommend testing their children, they And I'm sorry, I lost my train of thought there for just one second. So one of the bigger concerns is about insurance discrimination. So we're talking about testing children, minors who are perfect and healthy and young and carefree. And if we're saddling them with some genetic diagnosis at such a young age, is that going to cause them problems in the future? Thanks to a law way, way back in 2008, there's a federal law in place that prevents that type of discrimination for health insurance and actually employers. The Affordable Care Act strengthens some of those pre-existing condition protections. And then the state of Florida, about 3 years ago now, we actually were able to get past what we call the GINA expansion law. So the federal law is called GINA, Genetic Information Non-Discrimination Act. And so we passed that law. I say we, obviously I'm not in the legislation, but it's a big effort to get that passed, where take those limited protections from GINA that only apply to health insurance, and now they're expanded in Florida to cover life, long-term care, and disability. And we were actually the first state to pass such a GINA expansion, which was pretty exciting. So there are some protections in place, thinking about other concerns like costs. Those have also come down quite a bit. Insurance companies generally are fairly good about covering this type of testing. There's a lot of assistance out there for that. And then I think a lot of times people wonder, well, what does it matter if I know my mom had a Pheo and I might get a Pheo? Well, that's interesting, but who cares? And I think that one of the important things for people to remember is how much that screening can help in terms of early detection. Knowing that you have that risk before going into a surgery is very important to make sure that you don't have any of those impacts from some, what was the word you used, doctor? It was the Pheo crisis. Is that, no, I can't remember. Is that what it was? That just sounds like something you should avoid to me. So, this information can help protect people, not just, in terms of getting that information to their family members, but also then for themselves.
Yeah, I do. I love your comments, because it's very similar to what we talk in clinics with my patients. I always warn them beforehand that I'm sending them to genetics, and I tell them, this is important not only for your family members to be able to potentially be diagnosed early on, but it can also give me information about, do I need to do anything else different for you to prevent another tumor or another condition to develop? Do I need to involve another specialist? It's just kind of putting that perspective that, it really adds a benefit both ways, both for them and their family, I think is crucial.
Yes, we want to be working within prevention rather than treatment, and that's the goal of our mission statement, actually, to get there and to learn how to screen.
Exactly.
Well, thank you both. I think that will build on to discussion in next. But I'd like to introduce Dr. Rachel Voss, who is a surgical oncologist, also joined us from Texas, where she trained at MD Anderson. And she has a special interest in minimally invasive surgery, so she's able to offer that for her patients that we co-treat. Dr. Voss?
Great, thank you. Hello, everyone. I do have some slides. So let me try to share. It looks like it's not going to share in presentation mode. Let me see.
There we go. We can see your slides.
Okay, great.
You can, if you wish, you can put it onto slideshow, so it's one slide at a time. But otherwise, this is fine.
Oh, there we go. Okay. All right, so I want to give kind of an overview about surgery. And some of you listening to this may have already had surgery, so maybe you know a lot more than others. But this is what I look like, not in Zoom, since sometimes the Zoom is kind of hard to see what people look like. And as Dr. Haider said, I'm a surgical oncologist here at Moffitt. The adrenal gland. So as Dr. Augusto already mentioned, you have two adrenal glands. They live on top of the kidneys. This is just a little depiction of where they live in the body above the kidneys. And the adrenal glands have multiple layers. So there's like an outer, this like yellow layer here, and then the inner layer. And for our purposes here, the inner layer, what we call the medulla, is where the pheochromocytomas can originate when they come from the adrenal gland, this inner layer, the adrenaline producing tumors. For paragangliomas, those come from the paraganglia, which I think was mentioned earlier, are outside of the adrenal glands. And this is just kind of a depiction. These gray lines here with these little circles on them, those are a depiction of where all the paraganglia are located in your body. So it's like two lines of basically nervous type tissue that goes down from your head and neck all the way down through the chest and down through the abdomen. This is really deep in your abdomen. So like anywhere where you see these kind of gray spots here is where you can get the paraganglioma. And then, these yellow glands here again show the adrenal gland, and that's where we get the pheochromocytomas. So, under the microscope, the cells actually look exactly the same. It's just kind of a nomenclature thing. When they start sort of in the middle in these paraganglia, we call them paragangliomas. When they start in the adrenal glands, we call them pheochromocytomas. It's just how we've decided to name them. So there's really three kind of major approaches to surgery that I think about for each of my patients when I see them when we're talking about surgery, either for the paragangliomas or the pheochromocytomas. So I have them listed here and we're going to go through them. So first is the open approach. This means you get sort of a traditional big incision somewhere on your abdomen. If it's for the adrenal gland, usually you'll get like an incision under your rib cage, which is depicted up here in the corner. Or if it's for a paraganglioma, usually you'll have an incision kind of down the middle of your belly. When I operate on you, I do the operations in the belly. If you have a paraganglioma up in the chest, you might have like a thoracic surgeon do that. But the good thing, for the surgeon, when the open approach is that we can usually see everything well, we can get our hands on the tumor in there. And some people would say there's decreased risk of rupturing the capsule of the tumor. I have a photo down here of from my patients. This is a pheochromocytoma, and that's just what it looks like. It has this little like capsule of tissue around it. The cons to this approach is that generally the patient will have more pain because it's a bigger incision. The recovery will be a little bit longer. And the risk of hernia from the incision is the risk is higher because it's a bigger incision, obviously. So who are the patients that might get an open adrenalectomy or an open surgery for the paraganglioma? So if you've had a lot of surgery in your abdomen before and there's going to be too much scar tissue for me to see with a little camera and laparoscopy, then I may have to do the surgery open. When we do surgery with laparoscopy and small incisions, I actually have to inflate your belly with CO2 gas in order to see. I almost make your belly like a little dome. And if the patient if your blood pressure can't tolerate that, we can't, do the little incisions. We have to make the bigger incision. The larger tumors, also, especially for the adrenal gland, if they're larger than 6 centimeters, often we'll need to do it open because the tumor is just too large to see well laparoscopically. If there is a concern for adrenal cortical carcinoma, which is a different kind of adrenal tumor, that's another reason we sometimes do open surgery. Or if any of the structures around the tumor are invaded, like the kidney or the liver commonly, then it's just safer to do it, to do an open surgery and not laparoscopically. Paraganglioma can be removed laparoscopically, but I just find that usually the location where they are, for the type of surgeries I do anyway, which is in the belly, they're really far towards the back, and it's just difficult to get to them laparoscopically. And so most of them I end up doing an open incision, because they're often right next to the very huge blood vessels in your body, the aorta and the IVC, which is the vena cava. It's the biggest vein in your body that runs through the back. This is a picture of a paraganglioma I took out a year or two ago now, that was deep in the patient's belly on the left side next to their aorta. Okay, the next approach or technique is a laparoscopic adrenalectomy or robotic. These approaches are similar. I have some images here just so you can get kind of a feel of what it looks like. This photo on the right is actually the surgical robot. It's what it looks like with the arms draped over the patient. You can just barely see the patient under there. And then what you can't see in this photo is the surgeon is actually off the screen sitting at a little console using what looks like almost like a little joystick or kind of plastic hands, and is controlling them and moving the robot. So the robot is there and it's just doing what the surgeon is telling it to do. The left image just shows how the patient is positioned on the table and where we put some of the trocars, where we put the camera and the instruments through in order to see inside the belly. This image just shows kind of what it looks like after we blow the belly up with gas. You can see the adrenal tumor. So this is a right-sided tumor because it's under the liver. Patients who are a good candidate for this have smaller tumors, usually less than 6 centimeters, low likelihood of an adrenal cancer, which, pheochromocytomas in the adrenal gland, the risk of malignancy, is on the lower side, and for Pheos, it is very safe to do laparoscopic surgery in those situations. And we do it frequently here. The third technique, which is less common for adrenal surgery specifically, this is not so much for paragangliomas, it's just for the adrenals and the Pheos, is posterior retroperitoneoscopic adrenalectomy. So this is where you approach the adrenal gland actually through the patient's back. And they're positioned like this, just in this photo, kind of after we put the patient to sleep, we position them on their belly with their knees padded and their chest supported. And you put these instruments in through their back, just under the rib cage and above the hip. And you, at that point, you're able to see the kidney, and you just kind of march up the kidney until you get to the adrenal gland, and you remove it that way. So the nice thing about this approach is that you don't have to enter the abdomen at all. You're just coming through the patient's back. And this is a really great option for patients who've had a lot of abdominal surgery before. I just did this on a lady like a week ago, and she'd had numerous operations on her abdomen, and it was going to be, pretty likely or fairly likely that I might have to convert her to the open surgery because of all the scar. I was concerned she'd have a lot of scar tissue. So we just went through her back and removed the adrenal gland that way. This is also a good technique because some patients need to actually have lesions from both adrenal glands removed, like VHL, patients with a VHL mutation. So I've done this for those patients where they had pheochromocytomas on both adrenal glands. And in one surgery with one position, I was able to remove both glands because you can access both when they're laying on their belly. Otherwise, if you're going through the abdomen, you have to flip the patient halfway through the surgery. And it's just nice to have another, option for patients. So, like was mentioned before about customizing your plan, we do that for our patients, not just from an endocrine perspective, but from a surgical perspective, we also customize the plan for each patient. The drawback to this technique is if you do have to convert to the bigger open incision, you have to flip the patient over, which can be a little bit cumbersome, and reposition them during the middle of the surgery. It's a different view for the surgeon. So most of the surgeons in the country who do adrenal surgery are trained initially as general surgeons. Some of them are urologists, but we generally do all our work in the belly. And this is a complete opposite approach. So it takes, it's a different set of skills operating through the back, and you have to be trained to do it, and you have to learn. So you have to have been at a center that trains you to do it. So there is a bit of a learning curve with doing this technique. The positioning, I had a picture before, kind of a cartoon picture, but this is like what the actual setup looks like. We have this special mattress we place the patient on. And the patient's already asleep when we're putting them like this. So it takes some time actually to get them all in the right position and make sure everything's padded. There's not too much pressure on their knees or their arms. I do have a couple intra-op photos. So this just shows, this is the view during the posterior approach, what it looks like. And this is a right-sided tumor because we're seeing the vena cava here. But you can kind of get a sense of how narrow the working area is here. You can see the adrenal mass, and here's the vein, which is an important landmark for surgeons because we have to separate this adrenal vein from the vena cava. And then, so that's just an example of what that looks like for people who might be interested what the actual view looks like inside the patient. So for laparoscopic adrenalectomy or laparoscopic surgery in general for these type of tumors, all patients are admitted overnight. They're usually allowed to drink clear liquids right away after surgery, and they have regular breakfast the next morning. And most of the patients go home the next day in the afternoon, which is why, we try to do the laparoscopic approach if at all possible, because it's just so much easier recovery for the patient. For the, open surgery for the bigger incision, most patients are staying in the hospital about 3 days, sometimes 4 days. They just need a little longer to recover from that. There's more pain because of the muscle I'll have to cut through to make the incision. All right, I think this is my last slide here, but I just put some frequently asked questions that I get that just come up like almost every week when I'm seeing people to talk about surgery on their adrenal glands. And number one is actually a very legitimate question. Can you live with one adrenal gland? And yes, you can. The other adrenal gland will take over the function. What happens if both adrenal glands are removed? So in that case, we'd say the patient will develop adrenal insufficiency, and that patient will require a strict medication regimen in order to survive. And if they are not taking those medications appropriately, it can actually be fatal. So when you lose both adrenal glands, which can happen, you become dependent on medication to live the rest of your life. Is there special preparation before Pheo or paraganglioma surgery? Yes, Dr. Agosto touched on that before with the alpha and beta blockers, and our endocrine team does a great job, preparing patients for surgery, and they're in great communication with the surgeons, if there's any hiccups happening or if they need more time to prepare the patient for surgery, we communicate back and forth to make sure everything's in place and that it's going to be as safe as possible to take the patient to surgery, to make sure that, their blood pressure is not going to get dangerously high during surgery. And frequently asked question number 4, do you take the entire adrenal gland or just the mass? So normally we take the entire adrenal gland. I'd say like 98% of the time we aim to just take the entire adrenal gland. So we're getting the whole gland and the mass out. There are some situations, especially for the some of the inherited syndromes, where we purposely will cut the gland in half and only remove the tumor, like the scenario I was mentioning where some patients have tumors on both adrenal glands and they need nodules on both adrenal glands removed. Then I will purposely try to save part of one adrenal gland so they don't run into situation in question number 2 where they have complete adrenal insufficiency and totally dependent on medications to survive. All right, and that's my part. Thanks for having me present today, and I hope you learned something, and we're happy to have you here at Moffitt if you ever need someone to see you.
Thank you. And thank you for spending time going over open versus laparoscopic, because there's such a draw to, you know, a lot of the questions that I receive before the surgery consult is, can your surgeon do this laparoscopically? And it is not always the best fit. So like you said, it's important to really design a surgery that fits that unique individual, that gives them the best cancer treatment, but also takes into account their whole healthcare. So thank you for reviewing that. And I want to highlight that you are trained in the posterior approach, and you were highlighting that it's not the usual way, so it may not be offered at every center, but we do have it here.
Yep, absolutely. Mm-hmm.
All right.
Yeah, and I love designing, you know, a plan for my patient. And I spend a lot of time, you know, understanding their history and what surgeries they've had done before. And, you know, I like to be really thoughtful about, you know, obviously I want my patients to recover as soon as possible, but I also want them to have the optimal cancer surgery. And if that sometimes means a bigger scar, then I'll tell them that, like, this is, you know, the pros and cons of the approach, and this is what I recommend that you have.
And we're in our last few minutes. Unless any of my other colleagues have questions, I had one more question for you, Dr. Voss, which is, we talked about a surgery to the primary, meaning removing the tumor where it started, but sometimes you also have a role of removing other sites. Perhaps if we have something that is not requiring medications like chemotherapies, but there's a recurrence that is isolated in another organ, you may rejoin the treatment and offer a surgery again.
Yeah, absolutely. We, you know, love to be involved in the care of those patients, you know, not just people presenting with their initial tumor, but even in situations, you know, it's great when we can participate in the care of someone and, you know, quote unquote, cure them of their cancer and remove all the known cancer. Sometimes that's not possible. And sometimes we do surgery just to improve someone's quality of life or to reduce, you know, the number of blood pressure medications they need. And, you know, we absolutely are part of that multidisciplinary team in tumor board to evaluate for that. And, you know, sometimes we have to say no, but we do it with, I guess, with good intent. You know, we also know the limitations of what we do, and we know that there can be irreversible consequences to some of the complications that can happen with surgery. And so we're very thoughtful about taking that into account to make sure we're giving you the best chance of having an improvement, the best outcome.
Any other questions?
I have a question for Dr. Voss that's kind of just out of curiosity. You mentioned that when you do the surgery through the back, that the patient is put to sleep and then moved to that position. What is the reason for that? That they have to move them after, like you can't just put them to sleep when they're on their
Because
belly?
anesthesia has to have access to their airway and their throat to put the breathing tube in.
Oh,
And they
that
can only
makes-
do it when they're lying on their back.
But
So
then
they
it can stay in there when you flip them.
yes, we very
Ah.
carefully watch
Right.
the breathing tube stay in while we flip them over.
Oh, okay. Yeah, thank you. I was just curious.
Yeah.
Yeah, a great question, actually. It's good to know. All right. Well, thank you everyone for joining, and this will remain available for future reference. And some of the topics we discussed, like genetics, we actually had another webinar earlier that really went deeper into different genetic syndromes, and Laura Barton was a participant in that. So you can also have access to that.